one of the problems that you have coming into this is, let's say you have surgery, and the surgery does well short term, then you have to go through a bunch of processes, and that's the right talk. And then say a year later goes by, and you don't feel like you're improved enough. Or maybe it's still bothering you, or something's still bothering you. Or worse yet, the thing that was bothering you before the surgery is now still bothering you exactly the same way. So what do you do? So I'm going to start this off from kind of a surgeon perspective. I'm going to hand it off to Chris for the rest of the non-surgical perspective, and then we'll kind of go back and forth a little bit. So what I'm going to tell you is a bunch of warnings. Just like Raj just said, Dr. Sinha just said, he's an orthopedic surgeon. He doesn't like the touchy-feely stuff, and he wants to just get it out of the way and get it fixed. There are warnings about surgeons in general. Number one, surgeons are really great at criticizing x-rays. It doesn't mean that they're necessarily going to find your problem, but they can say they can overread something long enough. They look at it long enough, they'll find a problem with it, even if there isn't one. Or they'll always think that the solution comes in an x-ray if it's not perfect. They will go after trying to fix the x-ray rather than trying to fix the person. This is a very common flaw for many surgeons, and so you have to be warned about that ahead of time. So just because 9 surgeons tell you that there's something wrong with your x-ray and therefore that needs to be the answer, well, if 9 surgeons tell you, it's probably likely. But if it's a couple or one surgeon that tells you that, doesn't mean it's the truth. It just means that it's an option. The answer is not always repeating surgery, is what I'm trying to get at. And you have to realize also that surgery is not magic. Surgery won't make you faster and better at winning the lottery. It will not help you. Your knee replacement will not help you play the piano. Like, these are things that you have to understand that every problem doesn't go away because you have your surgery done. And so understanding that makes you realize that the replacement itself fixes the joint part of it. It gives you the platform to improve the rest of your joint, but it doesn't fix every problem around that joint. There's still soft tissue. There may be something that's not related to the surgery that still needs to be addressed, and maybe that's not a surgical issue. It could be simply related to your preoperative condition. So in that comes the idea that we had just talked about, that you can't also relinquish your responsibility for your own performance. So some amount of this is, did you do your part in the way that the doctor is facilitating you doing so? And you can't discount that because there is a lot to be said for non-operative treatment. So the steps that I would take coming into to a surgeon at 1 year, if your knee is still hurting you, is first of all, ask your surgeon. Is this normal? What's the cause of this? Can you fix it? Is it even fixable? Do you have a plan for me, or do you need to refer me to another provider? And if so, do you know who that provider is, and what is your success rate with that provider? That's really important to get an idea of. And you individually can treat it like any other problem. So are you doing everything you can? Are you at your own maximum medical improvement? Because maybe you were a slug. Maybe you decided not to do. Maybe you decided to pick up, long distance cycling when you had never cycled in your entire life before, and now you're having aches and pains. I mean, that's kind of a reasonable thing for anybody to have. And then there are resources like we've been talking about today, BoneSmart being a large part of it. So you can actually likely find someone else with the same problem as you online and see exactly what they're doing. And then lastly, get a second opinion. There is no fault in finding a second opinion, especially after 1 year after surgery. There is no fault in getting 2 or 3 or 4 second opinions. So go to another doctor or other non-surgeon providers. Treat it like any other problem. Think about it as a new start if you're not getting the results that you're looking for. And with this non-operative stuff, I'm going to hand it off to Dr. Rogers because he is the expert in non-operative treatment.
Appreciate that. So whenever you deal with a complex problem, it's always good to have a team of experts on your side. And so that's one of the nice things about this forum is you actually have a non-surgeon as part of the team with you, and we have that in our practice as well. So we work closely with our surgeons to address these complex problems. Chronic pain is typically a complex problem. There's multiple reasons why someone may have pain. I just want to be clear, as a non-surgeon, I see a lot of folks in my office who maybe are seeing me for their back or their neck, who also happen to have a scar on the front of their knee or on the side of their hip. And I always ask them, how do you like the new joint? And the vast majority of patients are doing fantastic. So as a non-surgeon, I can give you that unbiased endorsement of joint replacement surgery. However, in the literature and in clinic, we see a segment of the population who continue to have pain, what we describe as chronic, longer than 3 to 6 months after the surgery. And so we have to identify the diagnosis. Just like any medical condition, you can't recommend good treatment until you understand the diagnosis. There are risk factors for developing chronic pain. This has been studied in the literature. Patients who have more severe pain prior to their surgery tend to be at higher risk for developing chronic pain after their surgery. Patients who are struggling with depression or anxiety are at increased risk. Patients who have other medical comorbidities, so perhaps diabetes or obesity or cardiac conditions, are at slightly greater risk for developing chronic pain. And then patients who, as you've heard before, can't participate fully in the rehabilitation process after their surgery often develop or can develop chronic pain. Interestingly, in the literature, there does not appear to be a strong association with the type of surgery, the type of implant, or even the duration of the surgery with chronic pain. So these are the kinds of conditions that I come across in my clinic on a regular basis. I'm just going to highlight some of them. These are conditions that would be managed best with non-surgical care. Obviously, if the patient's suffering pain due to stiffness in the joint or due to weakness in the lower limb, that's something that we would address non-surgically with physical therapy. Even though a patient may have had successful rehabilitation 3 years ago after their joint replacement, doesn't mean that they haven't become deconditioned since for other reasons. So a lot of times we just have to tune them up a little bit. Metabolic syndrome or chronic inflammation, systemic inflammation in patients who are obese or who have diabetes or other inflammatory conditions can develop a sort of a chronic synovitis that can be managed by making modifications in diet and addressing nutrition issues and rarely even steroid injection can be helpful for an acute flare-up of synovitis, although we can debate whether or not it's a good idea to put steroid in a joint after patients had surgery. More commonly, what we'll see are patients who develop soft tissue injuries, right? So as Dr. Chow alluded, many times this scenario arrives where a patient has pain after their surgery. Their surgeon has looked at the x-ray and hasn't identified the cause. I'm very fortunate. I have ultrasound in my office, diagnostic ultrasound, so I'm not just looking for babies, but I'm actually looking at soft tissues, tendons, ligaments, muscles. And this has been a real helpful diagnostic tool to identify soft tissue injuries that may have even been there before the surgery. I tell my patients a total joint replacement doesn't replace the total joint, it just replaces the articular surfaces. And it doesn't, if you have crummy ligaments and tendons and muscles before the surgery, you're gonna probably continue to have those crummy tendons and ligaments and muscles afterwards. So bursitis, a bursa is a fluid-filled sac that cushions the tendon. A lot of times patients can develop irritation of that structure, and usually that's easily treated with a little cortisone in the tendon. Ligament laxity is relatively common. I see this after knee replacement. I've treated a couple ligament injuries using, as I alluded to in the earlier talk, PRP or cell-based therapies to try to stiffen or regenerate some of those tissues. Neuroma can develop. There are large nerves that run along the knee. I actually have a patient who is a OR nurse and had a knee replacement and developed severe knee pain that was not diagnosed for a year. Couldn't even touch the knee, it was so sensitive. Got the ultrasound out, took a look at the nerve. Nerve was 4 times larger than the nerve on the other knee. Put a little steroid in there, a little lidocaine, took her pain away. I did have to repeat that treatment 6 months later, but she's able to resume all her normal activities. And then complex regional pain syndrome is a little more, as it implies, a complex pain condition where the patient is dealing with unusual swelling or warmth or abnormal sweating of the skin. This is the autonomic nervous system's getting a little confused by the trauma, and this is usually managed by our pain management physicians. And then finally, patients may have pain from another source. So common would be a sciatica or even hip arthritis can refer to the knee. So a good physical exam and some diagnostic tools are important. This is just a quick picture. This is actually in an athlete. This is one of our San Diego Soccer's professional athlete who developed a tear in his patellar tendon, and the big arrow is pointing to a black hole in the tendon, and then 12 weeks after having injected some stem cells from his adipose tissue, you can see regeneration of that tendon. But we see this also in our patients who've had knee replacement surgery where they have these persistent tendon tears.
So things that require surgical care, I'm going to really distill it down. So aside from infection, which we talked about a little bit earlier, so infection, a deep infection around an implant is a surgical issue. It's the only way you can clear it because there is not good blood supply to the implant itself. But if you really think about this as a broad picture, anything that's bone, anything that's hard, is mostly a surgical issue if it's injured. That's the stuff that's architecturally stuff that we can address. Anything that's soft, like really soft, like fat, like muscle, is primarily dealt with non-operatively. And then the gray area in between is going to be the ligament and tendon stuff, which can be treated operatively, can be treated non-operatively, depending on what it is and how it works. So if you think about that, the majority of the structures around your knee or your hip, for that matter, are things that do not require surgery to get better, that you will heal. So the stuff like bone and cartilage, that's the stuff that requires the surgical aspect of stuff. And that's why so many surgeons focus on it. And that's why so many surgeons that kind of have their blinders up to a lot of the other things that Dr. Rogers was just talking about. So the things that we're listing here are all things that directly relate to the hardware that we put in, like deep tissue infection and patella tracking and hardware loosening and fractures and ruptures and loose body, meaning pieces that are floating in there. Those are all mechanical things that we can address. But in the absence of a mechanical thing that we can address, we really need to facilitate your healing. And then maybe adhesions past about 3 months if your scar tissue is strong enough that you can't overpower it yourself.
So getting back to now conditions of the hip that might benefit from non-surgical care, they're very similar to what we see in the knee. So we can briefly go through this list: muscle weakness, joint stiffness, metabolic syndrome, which you mentioned earlier. Stress fractures, we don't see that too often, but some fractures can be managed with reduction of weight bearing. Tendinitis is actually a common thing that I see in the hip. We have the patient who's had the hip replacement, did a great job, great surgery. Now they can't lift their knee up, they can't flex at the hip, they have pain in the front of the hip. A lot of times the ultrasound will reveal injury to the what's called the psoas tendon or even the rectus femoris tendon. These tendons can tear or have tendinitis or what we call tendinosis, the degeneration of the tendon. I treat those, again, with new drug of choice, PRP, bone marrow stem cell, adipose cell, depending on the degree of the injury. For less severe injuries, PRP is usually sufficient. Bursitis, often treat those. There's a bursa that lives under that, what's called the psoas tendon, that can become irritated or inflamed. That often responds well to steroid injection. As we talked about earlier, metal fragments in the joint can cause sensitivity and synovitis. I don't see this particularly commonly in my practice, but what I do see more commonly is referral from the spine. Again, the sciatica, patients with stenosis, herniated disc, even joint pain in the spine can refer to the groin or to the hip area. So good physical exam helps us differentiate from those causes.
And then just like the knee, deep tissue infection as well, and anything that relates to the hardware. But the kind of crossover here, again, is in the ligament tendon area. You're talking about ligaments and tendon problems that are either refractory to conservative management and you need something more aggressive, or things that show like frank rupture that need repair. That's really the crossover. So, I mean, if you really have to put it in your head about what works well with surgery and what works well with non-operative treatment, think about pretty much everything works well with non-operative treatment except for some crucial things that are architecturally required for your body to work. That's really how most of this goes. And then the hypersensitivity synovitis is listed here because the easiest way to take care, or maybe the most direct way to take care of metal hypersensitivity, is simply removing the metal that you're hypersensitive to. And so that would be, I said direct way. I don't know that's a point of contention in our field as well. But that's it for what we have to offer on this port. Obviously, we could talk probably the entire day on just how to troubleshoot everything around a hip or a knee because they are such complex structures. So thank you very much for that section.